Good evening, and I'm very honored to be able to present the French initiative for cancer control, which started almost 10 years ago. As you might know, cancer is the first cause of death in France. We have an incidence of 365,000 new cases every year on a global population of 65 million people. And we have a mortality of 140,000 patients per year. So 10 years ago, the President Chirac decided that we should work on that and decided of a cancer control plan. It was the first cancer control plan, which was almost, I would say, mainly dedicated to structuring the landscape of cancer care. And this plan had 70 measures with 7 strategic areas of intervention. One of them was the creation of our National Cancer Institute, the INCA. This plan was evaluated by the Court of Auditors, and it showed that this plan had significantly moved forward the landscape of cancer care in France, because it was a real dynamics for professionals and patients. What is very special in the French cancer control plans is the integrative approach, mixing together measures dedicated for research, care, prevention, early detection, and after cancer social problems. We then moved to a second cancer plan, which was launched by President Sarkozy in 2009. And this plan was in a continuous action of the first cancer plan, but it had 5 main directions: research, observation of cancer, prevention and early diagnosis, quality of care, and life during and after cancer. This plan had 119 different actions, which were structured in 30 measures, and it was in accordance with other health plans, health plan, environment plan, palliative care plan, chronic disease, etc. We were lucky because this plan was funded and quite comfortable funding, with a budget of almost 2 billion euros of a Okay, thank you. In this plan, the French National Cancer Institute was responsible for following the implementation of the actions. We were also in charge of 50% of the actions of the plan, but there were also other pilots, charities, the Ministry of Health, and other structures. We were also in charge of identifying the difficulties and trying to overcome them. This plan had 5 major axes: to provide and accelerate transfer of research outcomes to all the patients, to have a better knowledge of cancers in France, to prevent cancers and to reduce incidence and severity, to offer to every patient a personalized and efficient care during the disease, and to increase the quality of life during and after the disease. Among these 5 major axes, there were 3 cross-cutting themes: to take more effective account of health inequalities, to encourage analysis and taking account of individual and environment factors, and to strengthen the role of the referring doctor. What is the assessment? We had main advances, and we can say that in research we almost succeed in all the actions. We had the target of increasing more than 50%, by more than 50%, the number of patients included in clinical trials, and we reached to increase by 70% the number of patients included in trials. We have now more than 37,000 patients included in clinical trials in France. We had to identify comprehensive cancer centers, and we identified, after a call for proposal, 8 comprehensive cancer centers. We had to accelerate access to target therapies and to double the number of patients benefiting from predictive tests for target therapies, and now we reach the number of more than 70,000 patients with molecular testing in 2013. We had also to open clinical biological databases, and we were part of the big genomic programs called ICGC. We were supposed to perform 5 sequences of the 5 main cancers, which are liver, breast, prostate, sarcoma, and retinoblastoma. In observation now, we have all the data on French patients concerning incidence, survival, mortality rate, prevalence, and all these data are public on our website, and we publish them every year. It's called The Situation of Cancer in France. We have reduced the delay of cancer registries, which is now a delay of 3 years to have all the data. I will go further. In prevention, I would say that it's not such a success, since the tobacco control remains insufficient, and the prevalence of tobacco use in France has increased again for the first time in the youngest people and in women these last 2 years. So we have a main effort to do on prevention, on tobacco control. We have now 2 programs, national programs for early detection, one in October for breast cancer, one in March for colorectal cancer. I would say that we didn't reach the objectives. The objectives for screening for breast cancer was 70%. It's only now 52% of women participating to the program. But we have to add to this 52%, 10% of women participating to an individual screening, which is of course allowed. So I would say that 62% of women are screening every year. For colorectal cancer, I started in 2008, and we are only at 32% of people participating, which is not enough, of course. We made very big progresses in healthcare, in quality of care. Now all patients have to be taken, all treatments have to be done in authorized centers, and that reduced the number of hospitals which are allowed to treat cancer patients. We had, at the beginning of the plan, 2,200 hospitals or clinics which were able to treat patients, and now there are only 880, I think, which is a big progress. There is also a criteria of quality for radiation therapy, and we organize special networks of care for oldest patients, for pediatric patients, for oncogenetics, and I will focus on that later on. I would focus now on two main initiatives, which is the strategy for personalized care. We launched a program to have a patient-centered approach, and I just said it, but it's a program dedicated for specific cares or specific populations. We have a rare tumor program which started a few years ago in 2009, and this rare tumors is now 23 different networks of regional or national centers in these networks who are taking care of rare tumors. We have specific centers for oncogenetics, more than 17 now sites of consultation on the territory dedicated to family cases. We have also networks for oldest patients, for young patients, for adolescents. And we also perform a tumor-centered approach of personalized care, what we call usually personalized medicine, with the molecular diagnosis of tumor, and now we are performing next-generation sequencing. So I will focus on the first initiative, which is the patient-centered approach. There is key success of factors. The first one is an integrated approach of what we are structuring. For example, for rare cancer specific networks, they are in charge of healthcare with experts in the regional or in the national expert centers, which are in relationship with local cancer teams. They are also in charge of research promotion in partnership with research organizations, and so they have to perform clinical trials dedicated to these rare tumors. They are also in charge of training for healthcare providers. They are in charge of information to patients and their relatives, and they are in charge of registries or databases to be able to increase our knowledge on these rare cancers. The other key of success is the principle of equity of care, to give to everyone in France the best possible chance. This principle is very important. It means that when we organize a new network or a new structure, we have to be sure that everyone on the territory can reach the network. And for example, for the older cancer patient population, it's a nationwide rollout of oncogeriatric coordination units. I will go further. The third principle, which is also very important to us when we organize networks or structures, is the steering. It's not only a bottom-up organization with expert centers. We want to be sure that they are performing the same quality of care, that they are answering to the questions that we ask them. We, as a national agency, we describe the main task of each organization. We regularly monitor the structures and the actors with an auto-evaluation of all the structures and all the networks. It's an annual evaluation, and if the evaluation is fine, we fund each structure in adequation with the request and the activity reported. The breaks that we find in these organizations is to define what we call an expert. As you know, a leader or an expert in a field is sometimes not only the most well-known people, but sometimes you have to find an expert by a call for proposals, and you have emerging initiatives coming from call for proposals. So we do not design expert centers. It's always with call for proposals and an independent international jury. The other problems we had to face is the lack of adherence of some professionals. Of course, everyone doesn't want to be structured, so you have to pay attention to ego and the work due to evaluation. And also the fact that the dedicated funding can be used for other targets. That means that you have to be really steering all these structures and all these networks. Another example of success of the second plan is the strategy for personalized medicine on a tumor-centered approach. As you know, there is a shift of paradigm for cancer treatment with more and more molecular subsets of cancer, which make every common cancer, each common cancer can become several different rare cancers due to molecular alterations. So the identification of biomarkers in these tumors is very important to, of course, improve our knowledge, to improve diagnosis, to improve prognosis, but also to develop target therapies. So right now there is 7 molecular tests which are that you are obliged to do in France to be able to prescribe some target therapies. And so we decided to organize the screening of these molecular biomarkers on the territories and to develop a nationwide provision of this molecular testing. To ensure this equity of access, we organized 28 different platforms dedicated to molecular biology. The objective of the platform is to perform molecular testing for all patients, free of charge, whatever the healthcare institution they are treated in, public or private, and to perform high-quality tests for leukemia and solid tumors. So now we're working with those 28 regional organizations that we are steering in INCA. This organization, we are sure that it benefits to all patients. All the tests are performed free of charge with a compensation to the local pathologist for the shipment of the samples. And as soon as a new drug is available, we try to perform the test to anticipate the launch of the test on the platform to be sure that the test will be available as soon as the drug will come to the market. And for example, with gefitinib, which arrived on the market in 2009, we started to allocate the funding of the 28 centers at the end of 2009. And as you can see, the number of tests of lung cancer tested for EGFR mutation now is over 20,000 patients per year. And this is, of course, possible because it's sparing money for the health insurance system. For example, for gefitinib, we spend less than 2 million euros per year for the EGFR testing for lung cancer. And this makes possible to identify 1,700 patients which are positive for EGFR mutation, and we will really benefit from the drug. And so the real cost of gefitinib treatment in France is 35 million. But we are sparing to the health insurance the 69 million euros that we are not using in gefitinib treatments for negative patients. So with such a calculation, we could show to the health insurance system that it's a very worthwhile screening to perform. We also want to ensure the best quality for this molecular test, and all the platform will be accredited with ISO standards very soon, and we are performing the external quality assessment of all the platforms. And now we are moving to the next generation sequencing in several platforms to be able to improve our system and make it less expensive. Also, what we found that it helped us to increase the inclusion of patients in early phase clinical trials dedicated to the evaluation of target therapies in France. So I would conclude on this molecular screening initiative, which had been operating for 5 years. It offers an equal access of molecular testing for all cancer patients in France. It's a fast implementation of molecular tests for new tumor biomarkers. It shows that molecular stratification can be successfully integrated into the healthcare system, but it is sparing money. It is an opportunity to improve patients' accrual into clinical trials. And so we will keep on going with this initiative. Now I will finish with few slides on our third cancer plan. The second cancer plan is finishing this year. The 4th December of 2012, the President François Hollande announced that he wants a third cancer plan. He understands the value of cancer control plan for French patients, and he wants this plan to start in 2014. So there was a hematologist, Professor Vernon, who was commissioned to make recommendations and to evaluate the several actions which were performed in the previous plans. The priorities of the President are the following. He wants us to make big efforts on prevention, on primary and secondary prevention. As I told you, that was not the main success of the previous plan. On research, he wants us, of course, to better understand the disease and to develop personalized medicine for all French patients and to coordinate research and care facility, which is really the vision of France, the integration of research and care. About cancer care, he wants to reorganize care facilities, to involve further the general practitioner, and to increase interaction between hospital and general practitioners. He wants also to improve the training of healthcare professionals, nurses, and specialists. And he wants us to improve social measures dedicated to life during and after the disease, such as access to insurance, access to school for young patients, or to favor return to work for cancer patients. The Professor Vernon report has shown that we need to reduce further cancer-related inequalities, which are very important in France. That we have to adapt our healthcare system to changes linked to progresses in cancer care, such as chemotherapy per os, which will change the number of patients which are actually hospitalized. He proposed several actions based on prevention and screening research, occupational roles, oncology training and practice, care pathways, and life during and after the disease, and also insisted a lot on the role of the general practitioners, which has to be reinforced. He gave us 424 recommendations. We will not be able to follow all of them. We are working now on this new plan. There is 5 thematic expert groups working on research, observation, and care, on formation. All these groups contain experts from the Ministry of Health, Research, Ministry of Work, Ministry of Environment, etc. And we are working with professionals, experts, to write the next plan on Professor Vernon's recommendations. And this new plan will be announced by the French President on the INCA's annual meeting the next February. So thank you for your attention.